Good evening, everyone, and thank you for joining me for this webinar and taking time away from your family. My name is Kathy Cabenzone, and for those of you who did not get a chance to maybe read my bio, I have been a dental hygienist for about 22 years, primarily practicing in private practice. I'm going to share a short story with you of why this topic is so passionate for me and why it can be important for you as well as your patients. Many years ago, about 30 years ago, before I was a dental hygienist, I was absolutely terrified of dentistry. Experienced really bad times in the dentist when I was a young child. It hurt. Maybe I didn't get numb. Not too sure why, but I was really afraid. So I had lost a filling on tooth number 2. Many years ago, the filling fell out, and I knew enough to keep the area free of food because that's what I thought would cause the pain. I knew nothing of what caused a cavity. And then, of course, we all know what happens. That pain hits. I was taking an over-the-counter pain med for 10 days, like every 2 hours, because that's how terrified I was to go to the dentist. But, eventually that pain becomes too intense and you cannot control it. So you have to go. So I went to a dentist, found one in my local county here, and I was going to be sedated and have that tooth extracted because I was terrified of having a root canal or anything else. The dentist who had to do sedation wasn't there that day. He had an emergency. So I saw another dentist. I did have nitrous oxide, and she actually convinced me to save that tooth and then shared a story with me and said, I can actually help you, Kathy, to never sit in my chair again because you are that terrified. You let me help you take care of the issues that I can see, save that tooth. I promise you, we can prevent you from ever having a cavity. I could not believe she had said that to me because I never knew that could ever happen. I thought you were just supposed to have cavities throughout your life. She had unfortunately left the practice, and the doctor who had started to take care of me didn't offer, nor did the hygienist offer prevention after that point. And unfortunately, one of the teeth that she ended up doing an endo on, I ended up losing that to reoccurring root decay. And of course, I didn't feel it because the tooth was an endo tooth. So my passion for that is I paid for that endo, then I had to go through the agony and the pain of having an implant and paying for that as well. And it could have been controlled and stopped with some prevention that could have been given to me during my visits at that office. So this is why I share that passion with you. It is so important for our patients to be able to give them that prevention and give them those choices to be able to make for themselves, and that education as well. Because a lot of patients, just like myself, have no idea what causes a decay. So tonight we're going to identify the prevalence of caries based on different age groups, review some of those risk factors. Some I'm sure you've learned, some may be a little new. Review evidence-based research on arresting and reversing decay, identify barriers to patients' acceptance of caries prevention therapies, move the patient from saying no to saying yes to caries preventive therapy treatments. So looking at the prevalence of caries in this country, we have to ask a few questions first. Does caries only affect children? I'm not too sure about you on the webinar, but I've heard many times that it's a childhood disease. Well, as an adult, I had caries. Many of my patients have caries. So think about what percentage of adults have risk factors for decay in your practice, and what percentage of adults in your practice who have those risk factors actually receive any fluoride varnish applications at their dental visits. So this is the prevalence of caries by age group in the United States. And you'll notice here in the gray is people who have had caries in their lifetime. And then the blue is those who have untreated caries. So you'll notice that age group of 6 to 11, the prevalence is under 20% of caries and less than that for untreated caries. Age group from 11 to 19 is a little over 20% for having caries, and a little under 20% for having untreated caries. Now start to look at the age group of 20 to 64 or 65 and older. Their prevalence of having decay is about 80 to 90%. And untreated decay is over 20% for that age group of 20 to 64, which is primarily a lot of the patients that we're seeing. And then as we grow a little older, our prevalence of having untreated decay goes to about probably 27%. Many of our seniors are living a lot longer, and they're keeping their dentition different than it was many, many years ago. So we have to look at, if we have so many of our adults that have carious lesions that have been treated and so many that have untreated decay, what are we doing to help this change these statistics and help prevent this? The prevalence of root caries is also an extremely high risk factor, especially for our adult population. There was a recent review on the global burden of untreated caries that found that caries increased after the age of 40 by about 35 to 40% of the people being affected by that. And it's expected to have a high proportion of the new caries in older adults due to that root decay. Due to the root exposures. Tobacco use and alcohol consumption also puts a person at a higher risk for periodontal disease, which will also cause that root exposure. And we'll get into that in a little bit later. So looking at some of the risk factors for caries, we know patients who have demineralization have a higher risk because they're already having a breakdown. Persons with periodontal disease, root exposure, heavy biofilm deposits, patients who are going through any type of radiation or chemotherapeutics, tooth erosion, bulimics, tobacco use, drug use, untreated decay, severe hyposalivation, orthodontics, and a plethora of other things that we have. So think about the patients that you've seen this week or the patients you've seen in the last month. How many of your patients had multiple risk factors? And I'm talking more about the adults because adults have higher risk factors than children do because of the other issues and the other environmental concerns that happen when we become an adult. So think about how many have those risk factors, have multiple risk factors, and how many are actually receiving preventive therapies in order to counter these risk factors. So why do adults have higher prevalence of caries than children? Because at-risk children receive more fluoride varnishes and sealants than adults do. There are more community prevention programs for children, and pediatricians throughout the United States are starting to apply fluoride varnish to children after the first eruption of their tooth. For those who read my bio, I have a great passion for public health. I've been involved in public health since 2007. And public health gets it. Everyone in public health arena, whether they're going to a dental hygiene school or whether they're going to a county health department or a federally qualified health center or a school-based prevention program, they get fluoride varnish. But unfortunately, only 10% of the adults are receiving fluoride varnish at their dental visits. And these are the at-risk adults. They don't have the community prevention for adults, unfortunately, and they have many more risk factors than children do. So this is why they have a higher prevalence. But I ask you, don't they deserve to have that same prevention that the children have? Don't they deserve to have the benefit of possibly not having a cavity or losing a tooth, or the cost of what it might be for them? There are other contributing risk factors for this. A lot of our patients only brush once a day. They do improper brushing techniques, as we know. They don't spend enough time brushing. They do frequent snacking on carbohydrates. They use non-fluoridated toothpaste. And even if they do use fluoridated toothpaste, they rinse after brushing. And they're replacing flossing with rinsing. So a lot of these situations create what we see on a daily basis. So some of the reasons that I've experienced, and I'm sure you have too, as to why adults may not be receiving that fluoride varnish at their dental visits. Some of it has been that they've never been offered that. I have a friend of mine who I met through the Florida Board of Dentistry when I served, and she is not a dental person. She asked me why she was never offered fluoride and her dental visits. She said her daughter always was offered, but she had never been offered, and she ended up having a cavity. And I said to her, I don't know why you weren't offered that. You should have been. So again, our adults are not being looked at as needing these types of prevention. Probably the number one reason is the insurance doesn't cover it because a lot of us are very insurance driven. A lot of patients believe it's a poison. It really isn't. It's a mineral. Patients say they don't eat sugar. I've had diabetic patients say to me, how on earth could I possibly have a cavity, Kathy? I don't eat sugar. So a lot believe it's only sugar that causes it. A lot of people believe that it's only for children because we've really promoted it that way and advocated for children. And a lot of patients really don't understand why they need it because they don't know the benefits of it. So we have to look at, yes, it's important for our patients to retain their teeth. It's important for them not to have a cavity. It's important for them to not have pain or cost, but it's so much more than just losing the teeth. Most of the systemic implications and consequences of dental diseases really come from periodontal disease due to the inflammatory response of that disease, as we know. But decay also has systemic consequences. And one of the very first one that I was introduced to was from a young boy named Diamante Driver. He lived in Maryland. Diamante Driver could not find a Medicaid dentist. He did not have a prevention program in his area that he was getting. He ended up with a cavity. The cavity could not get filled. He ended up with an abscess, and the pathogenic bacteria ended up going into his cerebral fluid and killed Diamante Driver. All of that could have been prevented if he had had a prevention program or was able to go to a dentist and have some of the prevention that we know is very, very effective. Some of the other systemic situations that we've seen due to caries is brain and liver abscesses were caused by oral infections of Streptococcus intermedius. They actually found in liver and ventricular drainage and blood samples, they found Streptococcus intermedius because it does go through the system. If you are having an abscess, it is going to go, those bacteria are going to go into the bloodstream. And many of us have patients who do not take care of their carious lesions. They maybe don't even know that they have a carious lesion. Maybe they won't come back to the dentist for another year. And if we're not doing that prevention, we're not there helping them. Additionally, I'm not too sure how many have heard of this, but there are a lot of people, it happens in my state, and I've done a lot of data research on this, going to the emergency departments. They don't call them emergency rooms anymore. They call them emergency departments for dental related issues. And almost all of them are due to preventable dental issues. In 2018, there are more than 2 million dental-related emergency department visits in the United States alone. 95% of those cases were due to pulpal issues. So the decay had gotten so deep. And a lot of people have dentists, a lot of people didn't have dentists. But again, if we can prevent this, we shouldn't be having this type of a burden of disease in our country. We are not a third world country. We have great means of prevention, and we really should be helping to educate our patients to move into more of a prevention model versus a drill and fill kind of a model. So how do you look at developing a new norm for prevention and the treatment of caries? If you don't have a prevention program developed into your practice, there are definitely easy ways to start one. First, the patients really need to understand the whys of the treatment and prevention. I look back at myself with my -10 dental IQ before I became a dental hygienist. And I say to myself, my gosh, I knew nothing. But what a shame. Not many people taught me. The dental community didn't teach much. They really shared more about their vacations and their kids' photos and asked about my cruises and vacations that I went on than teaching me about dental disease. It wasn't until I became a dental hygienist that I actually even knew bacteria was the cause of this. Give your patients options. We never, ever, ever should assume that they don't want prevention, that they would prefer to have a filling or a crown or even worse. Sometimes because we're so concerned about their finances, we assume that they won't want to say yes because insurance may not cover this, but really that's not our place to do that. We have to give them that courtesy to make their own decisions. The year I changed, or the day I changed doing that, because I used to do it too, I used to actually make the decisions because I thought I was helping my patients. save them money. A person had asked me how I would feel if I went to my physician and my physician actually didn't tell me I needed something because my insurance wouldn't cover it. And I responded by saying, well, I'd be absolutely horrified. My physician would never do that. And she responded and she said, exactly, Kathy. She goes, but that's what you're doing. She knew I wasn't doing it because I was a bad person. And none of us do it because we're bad. We all want to help our patients. But a lot of times it might be some of our own barriers that are causing us to not give our patients these options. And preventive does not always have to be done in the hygiene room. I'll get into that a little bit further down the line. A lot of us feel that that's the only time that a prevention can be done. And like I shared with you, pediatricians are doing it. It's being done in school-based programs. Every arena that a prevention program or situation can happen is a good thing for our patients. So looking at the American Dental Association and other governmental public health programs are looking at incorporating more of a medical model of care for the management of dental caries, because it has been identified that dental caries and periodontal disease are actually global burden of diseases, of chronic diseases in the world. So for years, for many years, they've been trying to figure out a way to decrease these statistics. We should not be having this high statistics of decay when we have proven effective ways of preventing this disease. So they want to do dental caries management, kind of moving it from that drill and fill, in that watch and overlooking or omitting, some preventive treatments, to going into more about caries detection, looking at that risk assessment and that classification of where your patient is, as well as that prevention and risk management strategies to reduce the risk of patients developing advanced disease and maybe even looking at how to arrest the disease process, especially when it's in that incipient stage or that earlier demineralization stage that many of our patients start out with. So looking at arresting or reversing, I was introduced to this a few years ago, and it was extremely exciting. You could have an incipient lesion, or you could even have a lesion, and you could use different factors such as silver diamine fluoride and 5% sodium fluoride varnish to actually stop and arrest and reverse what is happening. This has been used over and over again in different countries that don't have access to dental care. It's being used in public health arenas where there is no access to dental care. But most of you who work in a private practice setting, you can use this as well, because why should your patients have to go into having fillings, 2 and 3 surface fillings, crowns, pulpotomies, root canals? They don't need to. Also, this study did say, which this was surprised me, so I was interested in reading it, to arrest or reverse the non-cavitated carious lesions on coronal surfaces of permanent tooth. The expert panel suggests clinicians not use the 10% casein phosphopeptide amorphous calcium phosphate, the ACP paste, if other fluoride interventions such as sealants or resin infiltrated is acceptable. Also, because they're not saying that it may not help the patient, but they're saying it cannot actually arrest it and stop that. So they're saying that the fluoride varnish and the others are much more acceptable in helping to do that. So looking at either preventing, arresting, or reversing, which one do you think your patients would want? Do you think that they'd be okay with paying $37 to $40 for a fluoride varnish application either 1 or 4 times a year? Or do you think they really want to pay for that root canal or that crown or that filling? I kind of never looked at it that way when I was practicing in my earlier years. I was very concerned with perio because that's the focus of dental hygienist. It made me feel horrible when my patients had bleeding gums and their perio was progressing. But when the dentist would come in and do the exam, I'd just be like, okay, well, they need a filling. That's not my thing. That's the dentist thing. And then I kind of realized later on, it really was my thing. Another story I want to share is my son, who was a fluoride baby. which was great. He had fluoride, polyviflor. He did not have any decay in his permanent teeth. He went off to college, and you know what happens when kids go to college? Their habits change considerably. Mom's not watching them. Their diet changes, sleep patterns change, stress hits. And finally, my son came home when he was 19, and he had his dental visit with me. And I found interproximal incipient lesions on my son. So being that I had learned about fluoride varnish back in 2007 and started using it continuously and always in practice, I decided I was going to try to remineralize and reverse my son's incipient interproximal lesions in discussion with my dentist. So he was basically our first case that we used this on. I did not have SDF at the time. I don't believe that we had it here approved in the United States. So I did it with fluoride varnish, and then of course with some at-home rinses and honing in on that brushing and flossing. So my son graduated from college. He had come back one other time and his lesion had not grown, but sad to say that he had not seen a dentist again until he was 30. When I had finally asked him, Sean, are you seeing a dentist? He said no. So I found a dentist for him where he was, and I'm happy to report that those lesions, those interproximal incipient lesions, never changed from the time he was 19 to the time he was 30. So again, that showed me as a clinician that it really does work. So this is a clinical pathway. If you want to take a picture of this for non-restorative treatment, it's looking at permanent teeth, and it talks about how to treat the coronal surfaces and how to treat root surfaces. So coronal surfaces, if you're looking at the occlusal of a non-cavitated lesion, you would want to do sealant plus 5% sodium fluoride varnish, or the sealant alone. If not feasible, you would do the 5% neutral sodium fluoride, 1.23 APF gel, or 0.02% mouth rinse at home. But again, the best would be the sealants plus the fluoride varnish. And nowadays, sealants have fluoride in them, so no worries about sealing up an incipient lesion. It's done in the public health arena all the time. It actually can help to stop it. Or you would cavitate, and then 38% of this SDF solution. Interproximal for non-cavitated would again be the fluoride varnish, or resin infiltration alone, or resin infiltration plus fluoride varnish, or sealants alone. Cavitated would again go to that silver diamine fluoride solution. For facial and lingual, non-cavitated, you would do fluoride varnish or a 1.23 APF gel. Cavitated, go right to that SDF again. And then the root surfaces of the non-cavitated and cavitated, you would want to do 5,000 parts per million fluoride, 1.1 neutral sodium fluoride toothpaste or gel. If not feasible to have that, you would do your fluoride varnish, your SDF solution plus potassium iodine, or 38% solution of SDF alone, or 1% chlorhexidine plus 1% thymol varnish. So these are all the reports and the data and the proven science of how to actually incorporate a clinical pathway for non-restorative treatment. There are definitely times when people need restorative, but a lot of times you'll have a patient that'll say to you, I can't right now. My insurance doesn't kick in until January. I don't have the money to pay for a crown at this moment. So why not try to arrest it? You can always cavitate the lesion later. The patient can always have a filling done later, but why not try to stop the growth of that and prevent them from having a root canal or a crown, or worse, losing that tooth? So adding preventive options to your practice, you may want to think about going out of the box. Like I said earlier, hygiene is a no-brainer. Everybody thinks that's the only place you're going to get your fluoride care. But why does it have to only be at the hygiene appointment? I want you to think about that. So your patient is in the hygiene chair. Doctor has come in and diagnosed carious lesions. That puts that patient at an extremely high risk now, because if they have one carious lesion, there is demineralization in other areas of their mouth. That is proven science. So if that patient does not have fluoride at that time, or if the hygienist has not offered it, or the patient said no, why couldn't it be offered when they're doing the restoration on that patient? That would be a perfect time for the doctor to reinforce what the hygienist has possibly reinforced and have it done at the restorative visit. Or what about your patients who's been put into provisionals? I ended up having a lot of my big old MODBLs changed to crowns. I had some veneers on the front of my teeth, and I was in provisionals for a while. And sometimes our patients stay in provisionals longer than they should be. And I'll never forget sitting in an airport one day, getting ready to travel and do a lecture. I could not even open my mouth because the air conditioner was killing my teeth. My teeth were so sensitive to the cold. The first thing I did when I got back to the office is I painted fluoride varnish on my provisionals. It helped with the sensitivity. And again, it helped with any decay that could happen. So from then on, my doctor, who was a cosmetic dentist that I worked for at the time, we were putting it on everyone who was getting provisionals, because again, people are staying in provisionals too long, which they shouldn't do. So if they're not getting at their hygiene visit, it really should be considered at the restorative visit. What about ortho visits? Patients who have ortho, we have about 80% of our patients in ortho are adults. Their home care is probably no better than the children in ortho because it's hard to have good home care. They should absolutely 100% be receiving fluoride varnish. I'm confused as to why the orthodontists don't do it. I know some orthodontists do it, but I think they talk about, having that competition with the generals. Well, we share hygiene with the perios. We should be sharing fluoride varnish with the orthos, 2 times in general, 2 times at the ortho visits. Your perio patients, do they only see the periodontist? Do they only come to the general dentist for an examination or for a restorative situation because they're seeing the periodontist 4 times a year? The periodontist should be doing caries prevention also, especially due to the high exposure of root caries, and looking at what the acidity base for caries for a root actually is 6.5 acidity, where neutral is a 7. So a patient doesn't have to have an awful lot of acidity in order for them to get root caries. So providing that fluoride varnish at the perio visits. Also, if they're not providing it at the perio visits, the generals should be asking, are you receiving this at your perio treatments? If not, then it should be done at any restorative visits for those patients. And delving a little bit deeper into that, wait a minute, I think I missed one. No, I didn't. Looking at which fluoride is better for your patients, you have your gels and your foams. Gels actually reduce caries at about 20 to 50%. It takes 4 minutes. I'm not too sure about you, but 4 minutes is tough for me to be sitting there with a suction in and a tray and monitoring my patient. And many of my patients don't like that. Greater chance of swallowing the fluoride. This is really critical for your patients who may be anti-fluoridation patients. And it's not recommended for any child that's under the age of 6. Fluoride varnish has a caries reduction of about 50 to 70%. It has a much higher concentration. It's extremely quick to apply, and it's safe for every single age. I've done a lot of workshops with anti-fluoridation people, and a lot of them are not against having fluoride varnish at their dentist office. They're against having it put into their water systems. So just because somebody's concerned about fluoride doesn't mean that they wouldn't accept it if you educated them and let them know that the chance of systemic and swallowing would be very, very minimal. Looking at what matters in fluoride is actually the dose. Let's all remember that this is a mineral. This is found in many foods. It's found in apples and pears and potatoes and zucchini. And we eat these on a daily basis, and we don't worry about being poisoned by that. We understand that the function, it stimulates bone and new bone formation. It inhibits or can reverse early tooth decay. When ingested, only 80% is absorbed. 80% is absorbed in the gastrointestinal tract. 50% is retained and stored in the bones and teeth. And then another 50% is released in urine. There are some studies that show fluoride supplements may actually reduce bone fractures as well. So frequency of those intervals. When we look at our risk factors, patients who are at a low risk factor for decay, they would possibly be twice a year, low to moderate risk factor. I'm a little bit more aggressive. The moderates, I put them, especially if they're at a moderate rate for root caries, because root caries, we all know that that's dentin, and the blowouts that we could see from 3 to 6 months is extremely high. So I would do more than 2 times a year for moderate risk of root caries. But high risk patients actually should be having fluoride varnish 4 times a year. So if you have your patient only on a 6-month recare, they probably should be on a earlier one. But if they're not, why can't you just schedule them and have them come in and have the dental assistant do a fluoride varnish 2 other times if they don't choose to have that, dental hygiene full visit of care, whether it be perio maintenance or prophylaxis visit. Those are other options to do that. So why Fluoridose? I didn't use Fluoridose in my early years. I used pretty much the same one that all of you used. I won't mention the name. But Fluoridose has been awarded the Dental Advisor's top fluoride varnish from 2015 to 2020. It's 6 years in a row. It goes on really smooth. We do use it at the college that I work at. The students love it. The patients love it. I will tell you, there's not one patient at that college that says no to fluoride varnish. Not one. And it's not even something that's given as an option. They can, of course, say no to it, but it's so routine where the student explains it and says, we're now going to be putting this vitamin and this mineral back on your tooth to give it back the vitamins and the minerals that it's missing. That's how the students explain it. And very rare do we have a patient that actually refuses it. Patients don't complain about it being sticky and stringy. They don't complain about it having a yellow hue because it goes on clear and it stays on clear. It doesn't discolor the tooth. It dries in seconds and it remains on the tooth for about 4 to 6 hours. It's lactose-free, gluten-free, nut-free, but it does contain that rosin. Excuse me, I've got to close my door. It doesn't contain the rosin, so you do have to be careful if anybody has an allergy or sensitivity to that. You would want to ask that. So there's a 3-prong approach that you could take to preventive therapy acceptance. Review the patient's medical history and their lifestyles, because you will find out all of the risk factors you need to know in a quick review of those medical history and lifestyles. Discuss those risk factors, such as the medications they're taking. Do they have dry mouth? Do they smoke? Are they taking any, substance abuse? Are they drinking? Are they going through any radiation or chemo treatment? My mom went through head and neck radiation therapy. I went to her chemo room every Monday with her, and regrettably, there were 6 other people in there that had head and neck cancer. There was one woman who had told me that she had gotten fluoride varnish trays from her dentist. And after about her 4th week of radiation, she couldn't even put those trays in her mouth because it ripped it open. Her mouth was so raw. In this great state of Florida, I am allowed to place fluoride varnish anywhere I choose to, as long as I don't charge for it. So I brought in fluoride varnish for everyone every single Monday. And I was brought my gloves and my mask, and I was placing it on all of those patients with radiation and chemo. So again, if your patients are getting ready to go on radiation and chemo, I know that they need a clearance from the general dentist. Please incorporate a prevention program for them as well before they start their chemo and radiation. Looking at the clinical risk evaluation, do they have recession? Make sure you take your explorers and feel those root surfaces. Are they starting to get a little tacky? Is there demineralization around that? Looking at whether there's heavy biofilm, especially around that crown and bridge work where they can't remove all of that biofilm. Do they have existing decay? Do they have reoccurring decay? Do they have previous decay? When was the last time they had decay? Do they have erosion, ortho, open context? I know my patients, and your patients are no different than mine. 80% of my patients have these risk factors, multiple ones. So that's why you should be seeing a ratio of at least 80% of your patients having fluoride varnish, or at least having those discussion of the benefits of fluoride varnish for those patients, and not having it to be the statistic of 10% of your patients in private practice having fluoride. Share that fluoride is non-toxic. It goes on quickly. It is not sticky. It dries clear. Some of the patients may have had it 6, 7, 8, 9 years ago and are like, oh no, I don't want that stuff. Let them know it's changed. Let them know it's improved. Share the risk factors and the consequences for the decay, or worse, what could happen, losing a tooth or some systemic consequences. Many of our patients who do get decay don't take care of it right away. We do not know when a systemic consequence from that can ever happen. So if we could be that frontline educator and that prevention specialist, my God, that puts us on the front line of medicine as dental hygienists. So we're also looking at avoiding some of the communication pitfalls. I've talked to thousands of hygienists in my career. I've been so amazingly blessed to have met so many great people and great clinicians. I've been mentored by some amazing dentists and dental hygienists as well. And I tell you, I had probably every communication pitfall you could imagine. But my patients taught me a lot. So I started to listen to them. And I started to avoid some of the pitfalls. My first pitfall in communication was I wasn't saying anything. I wasn't telling them. And when I did, I started to ask, do you want this? Well, if I ask and I'm kind of skeptical about it, whether I believe in it or not, and I'm kind of sheepish and a little, worried about their response, they're definitely not going to have much confidence in me. I also had to avoid being insurance-based and worrying so much their insurance didn't pay for it, because I could say things like, your insurance doesn't cover it. Do you still want it? I mean, that's not really encouraging, and it doesn't act as if I truly believe in it. Not telling patients what they need because you think they don't want it or they can't afford it. Trust me, I made that mistake way too many times, and I regret that. I promised myself that day that somebody asked me that question, I never made another decision for my patients, because it wasn't my place to ever do that. Remember, you're the expert. They want to know what you say. There was a student who had a patient, was Tuesday at the clinic, young man. We were going through his radiographs that he had sent from his private practice. He had no decay. She had asked me if she should take new radiographs, and I had said to her, well, let's look what his risk factors are. So we looked at his medical. No medications, no risk factors, young man. Diet looked pretty good. His films that he had, which were only a year old, showed no decay whatsoever. So I said, well, have you looked in the mouth and done the clinical assessment? She says, yes. She goes, I think there's some incipient decay and there's some staining on the occlusals. So I sat down to look, and I blew air, and there were some incipient lesions. So in the great state of Florida, dental hygienists who work in a clinical program are allowed to diagnose, because we have to teach. So we had a discussion regarding that, and the patient was like, no, I've never had a cavity. Please don't tell me I have a cavity. And I explained to him how we could reverse that, how we could help to prevent, because if this area has started, trust me, there's other areas in the mouth that I cannot see yet, or the radiographs cannot pick up yet. And I said to him, let me ask you a question, because I knew I was doing this presentation tonight. I said, if your dental hygienist had ever said to you, we could give you this for, say, $40 to prevent you from ever having a cavity, and explained why, would you have said yes? He goes, of course I would. Nobody's ever asked me that. So again, give them the information in a language they understand. Teach them. Don't make their decisions, and be part of that prevention expert that you were trained to be, because that's truly what our licensure gives us that gift to do. This was an interesting study of what patients really want from us. Many of us feel that they don't want us to give them bad news, or don't want to talk to them about additional costs, but it's really not true. They want us to be confident They believe that when we're confident, they're more confident. They want us to be empathetic, of course, and to understand, but communicate to them. They want the dental team to be interested in them, interact with them, and remember them. They want them to be frank. Tell me what I need in plain language. And be thorough, be conscientious, and be persistent. Sometimes a patient will say no because they still don't understand. So persistence is okay, because if you truly believe what you're doing is the right thing for that patient, you have to keep trying to convince them that it's the right thing. If it didn't work at one visit, do it at another visit. And just keep trying, because you can't give up. Then I got to move, my slide is locking. And then trying to connect those risk factors. I learned in my early years, when I tried to perfect my communication and my dental hygiene structured assessment of incorporating that patient in it, I started to ramble a little bit more than I should have. And I was giving information that really didn't pertain to the patient. So really make that connection of those risk factors as they pertain to what you're seeing with the patient. If anyone of you want to take a screenshot of this, please feel free to do so. So you could say something like, in reviewing your medications, many of these cause dry mouth. Is that something you're noticing? Our saliva has key properties that combat the process of decay. Being your saliva is lower than normal, you are at a higher risk for cavities than you were before. So this means we need to do more for you to help you fight cavities. No one wants another filling or crown. So we're committed to helping you prevent this. Again, looking at a medical model, when something's changed in your body or in your medical history, or you now have a higher risk for something, whether it be for cancer, whether it be for high blood pressure, whether it be for diabetes, your physician would never treat you the same way that they treated you before you had these changes or risks. We in dentistry need to incorporate that medical model and stop treating every single patient the same way, irregardless of their risk factors or the changes in their health histories. So explaining the whys of prevention, again, if you'd like, please take a screenshot of this. As you saw in the mirror, there are some areas on your teeth that have started to break down due to bacterial acid attacks. Sometimes I don't even say a cavity because they don't know what it is, but I'll say break down due to acid attacks. They know what that means and they know what bacteria means. The good news is the breakdown does not need a filling or a crown yet. To reverse this, the doctor is going to want me to place a fluoride varnish on your teeth to strengthen the areas that are breaking down and prevent other areas from having the bacterial acid attacks. Handling the, does my insurance cover this question? Because you will get that question, I'm sure, and I'm sure you do hear this on a daily basis. I had heard this more times than I can care to hear it. And I truly always believed the minute I heard that, that patient was going to say no. But when I really looked into it, where in that question does it say no? It really doesn't. Patient may want to know, does it covered? And if not, what's my out-of-pocket expense? Dental insurance is very limited. It is more of an assistance. The cost of this therapy to prevent decay is whatever it ranges in your practice, which is much cheaper than a filling, crown, or losing your tooth. Prevention is always better than treatment. It costs less and it doesn't hurt at all. And then finally, transferring this to the clinical team to help your admin team support the prescribed therapy. You could say something like, Katie, Mrs. Jones came in for her dental hygiene visit today. After her exam, Dr. Smith prescribed a crown for one of her teeth on the lower left. Also, the doctor prescribed fluoride varnish, which I placed today to help protect the other teeth from getting decay. Please schedule her as soon as possible, as we want to stop the decay from causing a root canal. And then I want you to have a thought to consider to take away, kind of in addition to the story that I shared with you about how when my doctor would come in and diagnose that a patient needed a filling or a crown, it didn't seem to bother me as much as their periodontal condition, because I felt that was more on the dentist side of it. So I want you to think about, how do you feel when your patient needs a crown or worse, and you never recommended fluoride varnish for that prevention, or never had that discussion? the patient can still say no. But if you did everything that you can do in your power to educate them, to treat them, to do those risk assessments, to talk to your dentist about it, to incorporate it possibly in other avenues, whether it be in the restorative visit and the ortho visits, and teach your patients, then you did everything that you're charged with by the license of your great state in helping to prevent this global burden of disease that we have, because we really do need to feel bad if our patients end up having a cavity or needing a crown or losing a tooth, when we know we were the prevention experts and we were the ones that actually could prevent this or reverse it if it was in its earliest stage. With that, I would like to say thank you and open it up if there is any questions. All right, I do have a question. Can a sealant be placed over silver diamine fluoride? Wow, that is a great question. I do know that a lot of times when SDF is done, that they will go in and do a resin composite over it when they finally do get the person to a dentist to do that. I don't believe that I've ever known that anyone's done sealants over SDF, but I want to check into that. And I wish there was a way I could get that information to you. What can be done to get insurance companies to cover varnish for all adults? Oh, great question. Unfortunately, insurance companies are designed to make money. They really don't look at prevention for adults, because again, we have always coined this as a childhood disease. But I think the more that you code it out and have it shown, whether the insurance company rejects it or not, and tell your patients, because this was something we did years ago for perio maintenance. Your patients it's actually their work environment or the benefit that they get from their employers that determines what can be on their insurance. So they can call their insurance company and say, why aren't you covering this for me when it's been evidence-based proven? Could you give me more tips on how to explain the benefits of fluoride varnish to patients that are scared or anti-fluoride? I think the best one for that really is to let them know that it is a mineral. Let them know that it doesn't go systemic. It dries immediately, so it stays in the teeth, on the teeth. You do need fluoride. We have fluoride in our bodies right this second. You are not adding any more poison. Letting them know that the problems with overfluoridation was more about how many parts per million, that it was overused in certain countries in their water fluoridation, which is not done in our country. What can be done to get insured? Okay, I read that one. Would you mind sharing how you would answer your patient when they ask, how does fluoride work? I find myself struggling to use layman's terms. Great question. Nobody's ever asked me that question. Basically, what I say to them is this fluoride, what it does is it works to counter. So when the bacteria acids hit your teeth, it drops acid and it breaks down your tooth. What the fluoride does is it comes in and it has a chemical composition to reverse that and actually re-strengthen your tooth. You can also share with your patient that a tooth that has been remineralized due to the fluoride process is actually stronger than when it first got mineralized during the development of the tooth. What toothpaste is best for infants 1 year old? Wow, that I cannot answer. I would like to do more research on that as well. I've never taken care of a 1-year-old child, except for my son. And at that time, I just used whatever my pediatrician had told me to use. We purchased some SDF. Let me scroll down here. And it says age 18 or over. Do you know if there are any age limits on this product? None that I know of. I've used SDF on my 3-year-old granddaughter. Not too sure if you remember one of the first pictures of some of the mistakes that people make. There was a young girl with blonde hair flossing. That was my 3-year-old granddaughter. Don't let the flossing fool you. She ended up having 3 carious lesions, and we did SDF on her, fluoride varnish on her, because she had very, very high sensitivity to noise. And her pediatric dentist had said, if I don't sedate her, I can maybe do 1 cavity, but I'll never get her back in my chair. So they wanted to do pediatric conscious sedation to my 3-year-old granddaughter. And I was like, no way. So I worked with a pediatrician and I said, let me SDF her, fluoride her. You look at her every 6 months and you tell me when we have to. And I will tell you that held it off for 1.5 years till she was old enough. It still wasn't a good situation, but it held it off till about 1.5 years. So I've never not given SDF to a child. Can we apply fluoride if patient has fluorosis? Absolutely. Fluorosis was done during developmental. How do you know now if they don't have demineralization, especially on the occlusal surfaces? If they're at a high risk and they've got incipient, they're diminished in their saliva, they've got other issues going on, absolutely, you won't cause any more fluorosis problems. Do you recommend sealants to adult patients with restoration margins visible? I recommend sealants anytime they're applicable for any age. Why are sealants, again, only for children? That gentleman who was at the college on Tuesday, we did the fluoride varnish treatments. We did an SDF treatment on him, and we placed sealants in all the teeth except for the 2 teeth that had the incipient. The doctor wanted to look at it again before she decided to place the sealant. If someone is on Prevident toothpaste as their only toothpaste, should they also have fluoride varnish at their dental visits? Again, depends on what they're doing with the Prevident. Are they brushing with that and rinsing it afterwards? It kind of counters the effect. What is their risk factors? Some of these people that have root exposure, that have high risk for root caries, who have high risk for caries alone, they need home and in office procedures. So again, it's all based on risk factors. If they're on Prevident, I'm sure they're at a very high risk. So I would say yes. Sealant should not be placed over SDF. You need to monitor tooth and reapply if or as needed. Thank you very much for answering that. I appreciate that, Beth. Does FDS cause the teeth to turn black? Great, great, great question. We've used FDF at the college. I know many public health professionals who use SDF. It only darkens the decay, not the tooth. So the decay will continue to get black anyway. So the SDF will only make the decay turn a bit darker. That is it, not the tooth itself. Are there over-the-counter fluoride treatments that you recommend to high-risk patients? High risk, if they won't do a prescription fluoride at home, of course, ACT is always something that they can use. I will tell you, my granddaughter, she has hypoenamelplasia, unfortunately, in her adult primary molars now. And she is on fluoride once a month, varnish in office once a month, ACT every night, and of course, fluoride toothpaste. So again, it's all based on those risk factors of the patient, where they are. Are there, okay. Is Fluoridose available in Canada? Yes, it is. I just came back from a presentation in Vancouver, and it is definitely available there. And you'll love it. When you try it, you're absolutely going to love it. It goes on so smooth. It doesn't feel like you're putting a varnish on at all. Is varnish the gold standard? We always sometimes use 2% neutral rinse. I do have to tell you, it is now the gold standard, yes. That's why a lot of insurance companies don't even pay for neutral rinses anymore or trays. It's more the varnish because of the high uptake of the fluoride and the high probability of decreasing the risk for decay of 50 to 80%. What is your go-to prescription fluoride strength toothpaste? It'd be Prevident. Do patients express concerns about discoloration after silver diamine fluoride treatment? No, I've never had anyone, because we do a waiver and let them know that the cavity, the carious lesion itself, will turn dark. Actually, it turns dark pretty fast. So we show them, we get an intraoral camera and show them. I probably wouldn't do it on the facial of tooth number 8. And most patients wouldn't want that because they want to fix those fast. It's the molars, it's the class 5 on tooth number 15 that your doctor just goes, oh my gosh, are you kidding me? Or on the, the third molar that they're not going to extract, or an occlusal that they just can't get in and get it restored at a proper time, and you don't want the decay to grow any further. Do patients, here. For children, baby training toothpaste until they can spit, and then use fluoride toothpaste past a pea-sized amount, which is true. We all should be putting small amounts. Ribboning, I believe, was a marketing gimmick from the toothpaste company. Excuse me. If an adult patient is on a daily ClinPro or Prevident toothpaste, do you think varnish is still indicated? Absolutely. There is no contraindication from them having fluoride varnish on top of their home Prevident or ClinPro toothpaste. Remember, if they have root exposure, if they have demineralization, if they have other high risks, that home care is not going to be enough. Remember that pathway that I shared with you? They need more than just that ClinPro. They need to have the fluoride varnish. What percentage of patients accept SDF as a form of treatment? A lot of patients do, if you really do explain it to them well. I'm not a proponent of SDF being the final. Absolutely not. People need to take care of it. A lot of people may not be able to. They may put it off. We use it actually a lot when we see those occlusal surfaces. And when we say to the patient, if you can't get in within the next month or so to get this taken care of, we don't know how deep that cavity is. If you've ever used a Diagnodent, you can see the readings on that. And then you open up a lesion, and you're like, oh my gosh, how did it get? My doctor used to take pictures and be like, how did it get so far in? So a lot of times we do the SDF to tell them, hey, if you're going on a cruise, if you're going away, we have snowbirds. If you won't be back for another 3 months, let's do the SDF. Nobody's going to see it because it's tooth number 15. And this way, at least we can stop the growth. Would you explain it if you're uneasy about it? I would just say it's a natural mineral again. It's placed on the tooth. It's a liquid. It's very easily. It does not hurt at all. That decay that's going to get darker with time and grow bigger and bigger and bigger because it's a bacterial infection and it will continue to grow. If we place this on it, it has the chance of making the decay itself a little darker, but it also has the ability, due to its chemical composition, to stop the bacterial growth of that decay. What fluoride varnish with ACP do you recommend? Actually, at this point, there's controversial studies on that. A lot of them are saying that the ACP kind of inhibits the uptake of the fluoride. There are some studies that say that it has a higher reduction for the uptake of the acid attacks. But again, it's controversial. So I do not use one with ACP in it. I use one without that. What about patients who opt for fluoride treatments and report good home care regimen, but still get carious lesions? There's a reason they're getting carious lesions. It doesn't necessarily have to be about their home care. What else is going on in their bodies? Are they grazing all day long and having acid attacks? I go back to my preventive dental hygiene education, and I can still see my educator saying to me, every time they eat a carbohydrate, they will have 2 hours of an acid attack on their teeth. So if they are grazing all day long, they will have acid on their teeth dropping all day long for 2 hours. It takes 2 hours for the mouth to go back to a neutral position. Does SDS stain less than others? I don't know any other preventive that stains a carious lesion, but again, it's just the lesion that gets dark. It's not the tooth, and the tooth does not stain, and that carious lesion is going to get black anyway. Is fluoride okay to do every time 3 to 4 month recalls? Absolutely. I just shared with you in conjunction of discussing with my granddaughter's pediatric dentist, we are doing it once a month for her because that is her high. She is at an extremely high risk for caries due to the enamel development of her teeth. Most of my patients and almost all of the college patients are on 3-month recares and they get fluoride varnish every single time. Every single time. There's no contraindication to it. Most of them are at high risk. Do the teeth have to be dried with gauze prior to varnish? No, not with Fluoridose. Of course, you don't want, sloppy saliva everywhere, but no, I just basically paint it on. Sometimes in public health, when a child opens their mouth, you only have 3 seconds. So it's on the finger and you go around and slap it on those teeth. You don't have time to dry a child's mouth. They sometimes don't let you in there for very long. Are you flossing the varnish between the teeth when there are interproximal incipient lesions? I've done that, and I don't really know if there's any evidence or science that it's better or not. What I do is I do take, instead of that micro brush, I take more of a brush that's got, hair fibers on it, and I try to really push it into the interproximal areas. You mentioned not rinsing after using fluoride toothpaste. Does this apply to over-the-counter fluoride toothpaste too? I normally tell patients not to rinse after prescribed toothpaste. Yeah, because they're rinsing off the fluoride. All of my patients want to do that. And I said, if you're going to rinse with ACT then. So it keeps putting that fluoride back on there. Remember, every time you do your prophy with your pumice, whether it be, fine or whether it be coarse pumice, you are removing natural rich layers of fluoride from their teeth. So we really should be putting it back on there. Why do you buy SDF? Where do you buy SDF for kids? I do not buy SDF for kids. I get it from dental professionals. There's, it's distributed from dental companies. Do you need to apply varnish to buccal, lingual, and occlusal? Absolutely. Everywhere can have demineralization, and we don't know. Occlusals, because of the pits and fissures, of course, always more so, but absolutely everywhere. How long do you or should you leave fluoride toothpaste on before you rinse? I just brush and spit. That's it. Don't rinse. Wait about 30 minutes, just like you would with any other fluoride treatment. Shall we use SDF if kids only have decayed primary teeth? No, use it on any tooth. You don't want to lose primary tooth. You don't want to lose permanent teeth. Remember, children who lose primary teeth, they may need space maintainers. We don't want to have that. And then they have shifting and drifting when their permanent teeth come in. Do you recommend any preventive products, Basic Bite, xylitol gum? If so, others? Yes, and actually, the product we're talking about has xylitol in it, which is great. Xylitol gum is great. I love xylitol gum for that patient who does like to do their grazing and they, are eating cariogenic foods. I like to tell them afterwards, chew with xylitol gum. It'll help. It'll help you put your mouth back into a neutral. So those acid attacks slow down. Do you recommend, do you recommend a certain, I do, Fluoridose. Fluoridose is not sticky. If the one you're using is sticky, please try Fluoridose. You will absolutely love it. Clear, glides on beautifully, dries immediately. I do it within seconds and patients love it. I never, ever have patients complain. All right. Patient is bleaching their teeth, but you recommend patient is bleaching their teeth, but you recommend. They ask, doesn't the fluoride cancel out the bleaching agent? I have never heard that the fluoride cancels out the bleaching agent. I used to always, especially patients who did in-office bleaching, I cannot in-office bleach. I go so sensitive. So I have patients do fluoride varnish applications before that. I probably wouldn't put it on right after they're bleaching, but I've never heard that it inhibits or cancels out. Remember, bleaching dehydrates the teeth. How do you approach the topic of black staining on a carious lesion surface that is associated with SDF? I think I've probably answered this before, but I would tell the patient that it's going to get black anyway. If you do not get the cavity filled, it will eventually go black and rot more and eat more of your tooth away. So that black is going to get bigger and bigger and bigger and go on more surfaces. If we can control it until you can get a filling, then that little black lesion may not grow. Do you charge for SDF treatment? If so, what fee? Absolutely charge for services and treatments that we do. Our office, we charge $50 to do SDF. The college does not have an additional charge for that. I am on a need to wrap it up info here. Okay, let's see if there's any thank you. Is there a code for this course? They will go over that in a few minutes. Oh, okay. This talks about how would you categorize a patient? All right. So basically, I've got to wrap it up. Thank you so much for all the amazing questions. And I so appreciate your participation in tonight's presentation. And thank you for taking time away from your families and wanting to learn and wanting to improve the health of your patients. And please go back to your offices, have the discussion with your doctors, because this is really important. Again, it's a global burden in this world of disease, and it's our job to help prevent it. Thank you so much for your time.